everyone, and welcome to today's webinar, Prevention of Pathogen Transmission During Point-of-Care Ultrasound Use. In response to current infection diseases like COVID-19, HPV, and MRSA, specialty medical groups are publishing their own recommended guidelines, taking into account how ultrasound is practiced within their specialty, like intensive care, emergency A&E, anesthesia, and fertility specialists, which is relevant to the wider medical community. To achieve the full benefits in patient care that ultrasound brings, clinicians need to minimize the contamination risk for the use of probes and machines that move from patient to patient. Cost, practicality, and workflows are all factors that must be considered along with microbiology for successful infection control policy. The webinar will update you on the latest issues and recommendations from the College of Intensive Care Medicine Ultrasound Special Interest Group, recently published guidelines that are relevant to all medical specialty teams. I'd now like to introduce to you our presenter, Dr. Castello, Senior Staff Specialist, Intensive Care, Wollongong Hospital, and Co-Chair of General Ultrasound, Critical Care Ultrasonography, Special Interest Group. Dr. Castello is an Australian-based health professional. Castello is an intensivist and has extensive experience in echocardiology. He is the author of numerous scientific publications regarding echo. Education is his true passion, and he has been training doctors in the echo for many years. I'd now like to hand the presentation over to Dr. Castello.
Well, thank you, and welcome everybody online. I'm very happy to have the opportunity to speak to so many people about such an important and relevant topic. I'd like to begin really by providing some background as to why the College of Intensive Care Ultrasound Special Interest Group came to produce another set of guidelines. Our story really begins with exponential growth graphs, which I know a lot of us have been spending a lot of time looking at in recent months. But the exponential growth that I'm talking about and interested in is the massive rise in the use of ultrasound outside of the traditional departments of radiology and cardiology, so-called point-of-care ultrasound. Ultrasound is mandated for the use in intensive care, certainly where I practice, for vascular device insertions. It's a compulsory part of our curriculum for intensive care, and really it's part of our standard management for many common conditions, including cardiac arrest, pulmonary embolism, sepsis, and ARDS. Unfortunately, mandated use and increased use hasn't come with mandated funding. And we've ended up in a situation in Australia where most, if not all units, have modern, good quality ultrasound machines. But there's been significant underinvestment in the wider infrastructure needed for the safe practice of ultrasound medicine. And I'm talking about things like archiving, audit trails, quality assurance programs, trained technicians, and of course, most importantly, infection control. And so I very firmly want to place this discussion on the need to improve infection control within a wider debate on the need to improve how we practice ultrasound, how to practice it better and how to practice it safer. So, first of all, let's consider whether a problem exists with our infection control standards. Anecdotally, yes. The research is limited. However, the research that is out there is very, very concerning. Matthew Keys and his colleagues in Queensland in 2015, they took samples from ultrasound probes and machines in 5 intensive care units and 5 emergency departments. And what they found was that despite lack of evidence of gross contamination, there was trace evidence of blood contamination in 61% of probes and machines, and 48% of machines had positive microbiological contamination. I've listed some, but by no means all of the organisms that would be well known to you that grew on their samples. Now, contamination is really only the first step in infection control, and it doesn't necessarily mean or cause infection control, but it is absolutely an essential component. And if I consider these results in my own practice, when I went through my own intensive care department, I came to realize that the only medical device that moves from bed space to bed space and that touches the patient is the ultrasound machine. So the potential for transmission of organism and the potential for harm is very, very large. COVID really, in many ways, brings nothing new to the debate except to focus on the reality of consequences. If we continue to practice ultrasound with current standards of infection control, we will infect ourselves, we'll infect our staff, and we will infect our patients. Now, none of the intensive care or ED departments that were studied in Queensland had policies or protocols in place. And in some ways, it's a little bit surprising because there's a very well-developed, very coherent and consistent system of standards, regulations, audit trails that have been defined for the practice of ultrasound in Australia relevant to infection control. The problem with them is they're often very opaque, they're very poorly, have very poor engagement in how they're written. And this in no small part has contributed to the poor compliance with cleaning standards in ultrasound. Thankfully, in 2007, the Australian Society of Ultrasound and Medicine and the Australasian College of Infection Prevention and Control produced a coherent set of guidelines that took all there's nothing new in these guidelines, but it took all of the standards and the research that were out there and provided a very easy to read, easy to use document that defined for everybody what the standards were, what was expected of us in different situations. And really, it was a great addition. It got very wide acceptance in the ultrasound community. And I think a lot of people became aware of what was expected of us and what needed to be done. Unfortunately, I think it wasn't widely uptaken or wasn't particularly well received in the point of care ultrasound community, largely due to concerns regarding practicality related to cost, implementation, the time to clean, and in particular related to ultrasound cleaning following vascular device insertion. These concerns in turn prompted the College of Intensive Care Board to ask the Ultrasound Special Interest Group really to review what had been written in the 2017 guidelines and come up with some guidance relevant to practice in intensive care. And that's what we've done. The document that we've produced is based very much on the guidelines in the 2017 document. It's based on standards relevant in Australia. It's based on what evidence base, when it exists, that is out there, as well as expert opinion from intensive care, microbiology, and infection control. So what I want to do, my overview plan really for the talk is to take the ASUM ACIPC 2017 guidelines and really just provide a quick review of the core message or messages within it. I will also then step back and really consider how does the practice of ultrasound medicine differ in intensive care relevant to infection control. And in doing that, consider the financial, administrative, and practical considerations that are needed for a quality policy in this area. And finally, I'll then run through what are the specific recommendations that the Ultrasound Special Interest Group has come up. So the core message of the 2017 guidelines are that ultrasound probes, I'm not talking about the machine, I'm specifically referring to probes, are classified as reusable medical devices in as much as they touch the patient. And because of their reusable medical devices, they need to be disinfected. They cannot be sterilized because that would denature the crystals and the ceramics that form the probes. They have to be disinfected. And the level of disinfection that's required of the probes really depends on a risk assessment, the risk of acquiring organisms and transmitting organisms. Now, the tool that's used to assess risk is the Spalding classification. This is a very old system. It must be at least 40 years old. And it divides reusable medical devices, including probes, into three categories: non-critical, critical, semi-critical, and critical, depending on two things. One, the organisms that they may become contaminated with, but primarily it's based on their risk of transmission of infection. So non-critical devices are those that come in contact with healthy, intact skin that are not contaminated with body fluids. Semi-critical with wounds, for example, non-intact skin, mucous membranes. An example of this might be a toe probe or a toe study or a transvaginal study. And then critical studies or critical probes are considered those that come in contact with sterile tissue, which isn't particularly common in intensive care, but those devices that come in touch with blood vessels and with the bloodstream are deemed critical. And this, of course, refers to when we use needles, such as vascular device insertion, pleural taps, etc. And so we assign basically a level of risk, and based on that, we can then assign what degree of or what level of disinfection. So for non-critical studies, intermediate or low-level disinfection is appropriate, and for either semi-critical or critical, high-level disinfection is required for the probes. The disinfectants used, first of all, a disinfectant that is used on a medical device needs to be of an instrument grade, and these are regulated and regulated by the TGA or Therapeutic Goods Administration. There's low-level, intermediate level, and high-level disinfection dependent on the range of organisms that they kill. So let's begin with low-level disinfectants. They kill most bacteria that we meet, the exception being mycobacteria. They do have some activity against some fungi and some viruses, and this would include COVID-19. Intermediate level, again, low level, it has the same activity against, but it certainly has extended spectrum against mycobacterium, most fungi, and most, but not all, viruses. High level, the big advantage is that it kills most spores, and this, of course, is important with Clostridium difficile. So we have different levels of disinfection, but really there are only two methods that are used as disinfectant, and they are chemical methods and ultraviolet light. Now, there are different chemicals that are used, but the methodology or how these are administered come in different forms, either as white soaks or there is a sonicated mist version. And then in addition to that, we have ultraviolet light. So really, it may appear to be complicated at first, but the clinician has only one decision to make, and that is, if you are putting a probe over clean, intact skin that doesn't become contaminated with body fluid, then low-level disinfection or intermediate-level disinfection is appropriate. In all other situations, high-level disinfection is what is required. So it becomes a binary decision. For anyone, practicing ultrasound, it's well worth reading the 2017 guidelines, and it goes into much more depth about such as infective organisms that are important, more detail on the disinfection methods and their effectiveness, and other issues relevant to infection control besides. It's well worth a read. However, consideration of microbiology is inadequate when you want to develop a comprehensive set of recommendations for intensive care ultrasound use. Including the 2017 guidelines, most guidelines are, are very much centered around ultrasound as it has been traditionally practiced, largely in an outpatient setting, a very clean environment with a dedicated technician whose sole task is to acquire images and look after the machine. Now, intensive care is a very, very different environment, and this impacts on infection control. And I'm sure this applies to many other point-of-care ultrasound settings. We need to consider the specifics of practice of intensive care ultrasound medicine when we want to consider infection control. I'd like to take time to do that for a moment. So one of the things that ICU does is there are many modalities of ultrasound that are used. With, from vascular device insertion, transesophageal echo to surface TTE. Now, from a Spalding classification points of view, this means that we do non-critical, semi-critical, and critical studies as a routine part of our daily practice. And the consequence of this is that low-level and high-level disinfection methods both need to be available in your intensive care unit as routine. Now, all studies also have perhaps a common feature of being urgent to a greater or lesser degree. And this means that machines need to be available for these studies at all times, including times when the machines are being cleaned and disinfected. There's two ways to deal with that. You can either have multiple machines, or you need to consider having short disinfection cycle times. One or the other or both are what's necessary. Now, in situations of mass casualties such as COVID-19, these issues become more prominent. We need to consider who does the scans. As I've mentioned already, the traditional settings involve use of a technician who has, with the specific task of looking after the study and looking after the machine. This is exactly the opposite of what happens in intensive care. Studies tend to be done by a very large number of doctors with varying degrees of knowledge and skill, both of echocardiography, but also of infection control. Infection control methods are only ever as good as they are applied. And this means that there is a very large training burden relative to infection control within the ICU setting. Current practice in Australia, and I suspect many other places, is that doctors are tasked to clean and disinfect ultrasound equipment while simultaneously being asked to perform clinical duties. Now, this is at odds with all other disinfection of medical equipment. I can speak for myself, and I'm sure I speak for many, that I don't clean or disinfect any other piece of medical equipment with the exception of ultrasound. And it's inevitable that clinical duties will take priority over cleaning and disinfection tasks. So we've created a situation where infection control competes with patient care, and as a consequence loses out and is greatly affected by this. ICU is not a clean environment. There is a large amount of blood, there's a large amount of feces. Case series have shown, between 15 and 45% of patients have diarrhea while in intensive care. There's an endemic rate of organisms such as Clostridium difficile and other multi-drug resistant organisms. Again, the consequence of this is that low-level and high-level disinfection needs to be available as routine. So when we step back and look at how we practice ultrasound in intensive care, I think there are three conclusions to be drawn. I'll repeat myself again. Both high and low-level disinfection need to be available. We need to have either multiple machines or rapid disinfection turnaround times as part of how we operate. And also we need to have cleaning and disinfection performed by staff, adequately resourced with time, equipment, and training. And so what the USIG group have done is we've taken this and we've added it to the core message of the ACIPC ASUM guidelines to produce our own set of guidelines, and that are expanded somewhat from the original document. And these are broken down into three sections: general principles, specific recommendations, and some additional recommendations relevant to COVID. And instead of going through them one by one, what I would like to do really is to go through what I think are the important things that we have conclusions that we've drawn to, and perhaps explain to you not just the conclusion, but how we've come to these conclusions. Let's talk about ultrasound guided procedures first. This really is what prompted the USIG to be asked to write the guidelines, and it certainly is probably the area of most concern to people in the POCUS world. The Spalding criteria clearly require the use of high-level disinfection when the blood vasculature is in close proximity to the probe. So that really is what Spalding has required. Now, ASUM has taken a slightly different approach to this, and their recommendations are that low-level or high-level are acceptable following use of ultrasound-guided vascular access, provided the transducer is deemed to have remained at some distance from potential contamination. Now, this was a compromise made in response to concerns largely from emergency physicians about the practicality and the costs of performing high-level disinfection in ED departments following the very common use of vascular access. And they correctly point out that there is no evidence of clear benefit or harm in the distinction with the use of low-level or high-level disinfection, particularly given the standard use of sterile probe covers. Our recommendations are different. USIG actually is pushing much stronger and is strongly recommending high-level disinfection over low-level disinfection following vascular access use. And there were three reasons why we've come to this conclusion. First of all, at the end of the day, there are sharp needles being used, and the protection that is offered by sterile probe covers, in and of themselves, they don't guarantee that they will not perforate, and particularly in the context of needles being used in an emergency setting. So no matter what way you cut it, there is a risk of contamination that cannot be avoided. We feel that the idea of this term of some distance really is way too ambiguous, and for clinicians to be making in the middle of a busy medical procedure. But perhaps the most important point that I'd like to stress is there is very little difference in terms of cost and practicality between high-level and low-level disinfection, and certainly not enough to warrant the non-use of high-level disinfection, if at all possible, following vascular insertion. Next thing I'd like to talk about is the probe and the machine. The 2017 guidelines really specifically refer to probe-only reprocessing or disinfection, and this is because they are reusable medical devices. The rest of the machine is not a reusable medical device and really falls outside the Spalding criteria. But from an infection point of view, this makes absolutely no sense. It's self-evident that the machine can act as a surface for pathogen transmission, and it needs to be disinfected. And so what we've done in terms of providing guidance is we've really pragmatically made a decision to separate high frequency and low frequency areas of touch that warrant disinfection from low frequency areas. And our recommendations are as follows: that the high frequency areas, which are self-evident, it's the keyboard, the screen, the probe holder, etc., they need to be cleaned to the same level of disinfection and with the same frequency as that of the probe. Low frequency areas, such as the rest of the machine, they do need to be cleaned on a regular basis. Now, what about cost and practicality? Well, we've seen what's available already before, but when we think about cost, I think there are three components that need to be considered: capital expenditure, consumables, and maintenance costs. And all three need to be added up and considered. When you're deciding what to use for your department, you really need to consider these three components. But rather than worry about it, I think the best way of approaching cost and practicality is to actually define what they are, and then make your decision as to whether you find this burdensome or not. Two things to say. One, options exist, for high and low level disinfection, both with and without capital expenditure. I fully appreciate how difficult it is to get capital expenditure, but options exist where capital expenditure is not necessary. Second point to make is we went and looked at the costs of what was available in Australia. Now, these are sort of combined costs that really take on board capital costs, consumables, and maintenance, and also consider the costs not just of cleaning the probe, but of cleaning the machine, the probe, and the high frequency areas of the machine as a total. And the costs really were, from my point of view, I thought surprisingly low, between $2 and $5 for low level disinfection and $3 to $23 for high level disinfection. Similarly, in terms of practicality, the times needed for high and low level disinfection really ranged from very short 2 minutes to 3 minutes, and with a maximum of 30 minutes. The consequence really, and the conclusion that the USIG have drawn from this is that time and cost are not plausible barriers for the adoption of appropriate infection control mechanisms. These costs in absolute terms are not high, and relative to the cost of secondary infection, the costs of potential litigation, They are very, very small, and we really argue strongly that that certainly within the Australian context and our ability to fund medicine, that these are not particularly burdensome. What about the use of sterile probe covers? Well, firstly, the use of handmade covers, the use of Tegaderm strips, they were never designed for this, and they provide an ineffective barrier and should never be used. Sterile probe covers aren't actually medical devices and are not covered under TGA legislation, so there's no clear definition of what they are. There is good research to show that dedicated probe covers made for the purpose have a very low, not a no leak rate, and they also minimize the image degradation that they cause. And so our recommendation is that only high quality dedicated probe covers should be used. Now, when should they be used? Well, USIC has recommended, we've just really remained consistent with standards and mandatory standards in some cases, that probe covers should be used when in critical procedures such as vascular device insertion. Now, I know this differs from some other international guidelines, and there is room for debate here. We did not recommend absolutely mandating them for transesophageal use, but we do recommend their use. The point being that, I suppose, one, there's not a strong tradition of use within Australia, and certainly some toe probes are left in place for quite some time, and there is quite a bit of image degradation, so we do recognise that. I think the point about sterile probe covers is that, yes, I take the point from, let's say, the Intensive Care Society in the United Kingdom, which recommends but doesn't mandate them, that if you perform a high-level disinfection on a probe and can maintain that degree of disinfection until its use, then there is, little advantage in the addition of a probe cover. I think there are two arguments against that. One, it's very difficult to maintain that level of disinfection, and that usually involves the use of a sterile plastic bag anyway. Secondly, the sterile probe cover does offer a sterile as opposed to a disinfected surface. It provides some protection for your probe, and it also minimizes the soiling of the probe, so that makes cleaning and then subsequent disinfection more effective. So really on that basis, and to remain consistent really with current standards and I suppose current practice within Australia, we've gone with recommending that they be used in all situations, in all cases. Ultrasound gel. Now this is actually an area with quite a bit and a strong evidence base behind it. There are several well-documented case series of infection directly attributable to infected ultrasound gel. There are two things that you need to know about, you have to achieve when using gel. One, the gel needs to be sterile, and two, the packaging needs to be sterile as well. And on this basis, we're recommending the use of sterile gel single sachets in all cases. It is implausible that the bottle of ultrasound can maintain a clean surface throughout its lifespan within intensive care. Yes, it's feasible, it's possible, but it's impractical to do this, and we recommend against their use in all situations. Documentation is important. I think it's important that we will be judged on our paperwork as much as our practice, but notwithstanding that, documentation following high-level disinfection is a standard across all disinfection and sterility procedures for reusable medical devices. It's an area of difficulty because what's required is details of not just date and time, but who did the test, who performed the disinfection, the probe that was used, and also cycle times for various products depending on or procedures depending on what are used. Unfortunately, the documentation systems, again, have been developed really with an eye on the traditional users of ultrasound. With dedicated technicians, they work fine, but in the context of ICU, they do not work very well. And I think absolute compliance is going to be a struggle for many of us. Again, I would ask and urge manufacturers to try and come up with a system of documentation that would work better for intensive care workflows. Documentation following LOD is not mandated, but it is preferable. And finally, I think what I think is the most important issue and the biggest barrier to good infection control is the tasking of doctors to clean probes. To me, it just makes no sense that the only piece of medical equipment we're asked to disinfect and clean is ultrasound. It's a recipe for failure. And I think it's an artifact of the historical piecemeal funding that has developed for point of care ultrasound. Now, clearly doctors do have a role to play in infection control, but they share that responsibility with hospital organizations. So both doctors and or hospital administration have responsibilities, but those responsibilities are different. And I think it is highly incorrect and wrong that physicians are asked to consider prioritizing patient care against ultrasound disinfection tasks. And what USIG has come up with is that cleaning and disinfection should be the responsibility of adequately trained non-medical staff. I suspect this will be our most controversial recommendation. Doctors can be reasonably expected to assist with cleaning, subject to their ability and clinical demands, but we place full responsibility on hospital administration to provide equipment and resources, including human resources, for proper infection control. It is unreasonable that patients are exposed to unclean equipment because there is a lack of trained staff or staff with adequate time. What about COVID-19? We just really made some brief comments. I mean, I think point of care ultrasound has come into its own in its ability to assess without moving the patient, the respiratory and cardiovascular state. And almost all COVID patients admitted to intensive care will have been the beneficiaries of ultrasound medicine. And the two aspects of intensive care that we can provide to COVID patients, really, the basis of our management is supportive care and impeccable infection control. We did consult widely and got some expert infectious disease and microbiology opinion and confirmed that low-level disinfection is adequate for all suspected or proven cases of COVID-19. And so really, I want to sort of draw to a conclusion, really what are the recommendations that we came to? So we started with some general principles. So first of all, we acknowledge that ultrasound medicine is now an integral part of our ICU care. We recognize that clinicians and organizations both have responsibilities to minimize infection transmission. Doctors, if they're using ultrasound equipment, need to be familiar with the equipment, and that includes the infection control policies related to that. And we also recognize that there is a lack of research and a need for research to improve infection control. Specifically, our recommendations are as follows: the use of single sachet sterile gel only, the use of high quality sterile probes during invasive procedures, cleaning as a mandatory first step preceding all disinfection processes. In terms of choosing the level of disinfection between high or low level, we've really gone with the ASUM ACIPC guidelines with a few small exceptions as follows. That it's important to clean the machine as well as the probe, that high-level disinfection should be used over low-level disinfection following ultrasound-guided procedures. And we are consistent with the ASUM guidelines with mandating that documentation is necessary after high-level and preferable after low-level disinfection. And finally, probably the most important recommendation is that dedicated, trained staff, non-medical staff, should be tasked with performance of ultrasound disinfection. We did produce a chart to assist with what you need to do in various situations. And really that concludes my talk. I think ultrasound medicine has added greatly to the care of ICU patients, but we need to minimize the risks associated with that. And with that, I'm going to open up the discussion to some questions if you have any. Thanks very much for the opportunity to speak with all of you. I really appreciate it.
Thank you so much, Dr. Castello. So we're now going to begin answering any questions that the attendees have submitted regarding the presentation. As a reminder to all the attendees out there, you can still submit text questions through the question pane of the control panel. With that, Dr. Castello, our first question here, let me just get this pulled up. How do you manage a quick turnaround time in disinfecting probes between patients?
So, as I say, when we were choosing what equipment or not necessarily equipment, but what products to use, I think turnaround time was very important to us. We can really turn around a machine within 2 to 3 minutes. Just by the nature of the product. Now, one has to be careful when reading the literature provided by manufacturers, because they'll talk about cycle times for machines, they'll talk about drying times for chemicals, but this is not the time that requires you to do a clean, to remove the debris, to then apply the disinfectant. You then have to let it dry. But really, the turnaround time can be as short as 2 or 3 minutes if you choose the right product. So really, the way we did it is we chose the products, and it was a really big consideration in what products and devices that we chose in our department. And that's how we did it. I mean, we do have multiple machines, but irrespective, I think moving equipment down to SSD departments for high-level disinfection, I mean, that might be okay with a tow probe, but if you're a cardiovascular surgery center, you're going to need rapid turnaround on that time so that, two people can get sick at once. It does happen. Choose your products wisely.
Thank you. So our next question, what discipline do you propose the non-medical staff reprocessing probes at point of care should be?
Yeah, so I think so most intensive care units within Australia do have equipment officers who are tasked, who clean they clean the ventilators, they do that. I think at night, there are often senior nursing staff available that are looking after, if you use a CMAC blade, there really is no reason that they could not be tasked with doing that. Now, in smaller centers, I do fully recognize that, it's reasonable and it's possible that doctors can perform some of these tasks, but a couple of things have to be put in place for that. Number one, I think the doctor, if he has other clinical priorities, should not be expected to do that. And number two, the doctors need to be trained to do that. And that is actually quite an extensive barrier. So I think it's going to be a combination of equipment officers, senior nursing staff, and also the SSD departments. But I'd like to just maybe segue into, I think probably the real answer that I would like to see happen is, I think that infection control and the tasking of doctors is really based on a false premise of ultrasound being, somebody's hobby. It's not recognized as just being core ICU practice. And there's some serious under-resourcing of core infrastructure as a consequence. The best way to deal with this would be if intensive care departments had dedicated sonographers. If they had dedicated sonographers, they could clean the equipment, they could maintain the archive, they could be doing the quality control, they could be assisting with teaching, and they could be assisting with providing the clinical service. I think a huge burden is placed on practitioners who provide ultrasound services and echocardiography services to intensive care. So the ideal answer I would like to see is sonographers dedicated within ICUs. And I think this, I know this is a big change in practice and it's going to cost money, but for most units, and I think of the medium to large size units, this is completely feasible. For the smaller units, that perhaps is not going to be possible. But that's really what I would like to see happen.
Great, thank you. So this next one starts out with a thank you for your wonderful talk. What is the definition of intact infected skin? We have a lot of pushback in this requirement.
Gosh, I don't know if there's a specific definition, but I mean, to me, it's just clean, healthy skin, where there's no rashes, there's no breaks in the skin, no skin tears, no wounds. But I think another important component is that it's not contaminated by body fluid in addition. Having considered my own practice, I reckon about 40% of the cleans that I do are high level and about 60% are low level. Now, I do a lot of scanning. What if you didn't do a lot of scanning? I suspect that ratio might go up if a lot of what you're using ultrasound for is for vascular device replacement. But if it's infected, broken, things like shingles, or as I say, contaminated with body fluid, in many ways it's a difficult definition. I think it's a good question because you can never be sure, and one could argue that high-level disinfection would be appropriate, but if you want to completely eliminate the risk.
Okay, so this one, just a comment here, the recommendations are closely aligned with the findings of the UK Committee on Reprocessing of RMDs. And they also have a question, are you expecting an instrument-grade disinfectant to be used on the high-frequency portion of the machine, or is a hospital-grade sporicidal being recommended?
So if a device is not a reusable medical device, you can use a lower grade of disinfectant. The issue, I think there's two things to consider there. One, how many different products do you want to maintain in your inventory? And two, what is the impact of these disinfectants on the high frequency touch areas? Will they degrade your machine? Now, most manufacturers provide advice as to what products are safe to use on their probes, but very few, if any, provide advice as to what products are safe to use on the machine. If we're talking about touchscreen machines, then it's almost certain that non-instrument grade disinfectants can be used on these machines without any serious consequence. But for a lot of us using trackballs and keyboards, almost certainly all products will degrade the machine to some extent, and I think therefore instrument grade disinfectants are less likely to cause harm. So what I use in my own practice is we just use the same instrument grade on the rest of the machine. And I recognize that over the long haul it probably will cause damage to my machine, but that's just a cost that we have to accept. Within the guidelines, we have recommended the push towards touchscreen only. I see it as the only viable long-term option within intensive care practice. But it is a dilemma. So you certainly are free to use hospital grade, but will that be more damaging to the machine? The other thing to consider is the residual product that you're going to be touching. Certainly with high-level disinfectants, depending on how they are used, there is a little bit more nuance than the binary decision than what I've said. One does have to choose between high level and low level. But for example, if you were using a high level disinfectant on a toe probe, and it's going to touch a mucous membrane, that does need to be cleaned off with sterile water. So, and then some products provide that, other products don't. So some high level disinfectants are registered for toe use and some are not registered for toe use. Really what we do, as I say, is we use our high or low level disinfectants on the other parts of our machine, and we just wipe it off, sometimes with an alcohol wipe if residue builds up, or with just water.
Thank you. So our next question, do you include bladder scanners and Dopplers in these recommendations?
I would like to, but getting my department to use them is another issue. But again, they are machines that move from patient to patient and touch the patient. So yes, they should be cleaned. They are reusable medical devices. They absolutely fit into this.
Okay. Will this publication be adopted as the professional guidelines by CIMC?
So it was
CITM.
Sorry, the College of Intensive Care. So has it been endorsed, I think is the question. So the document went to the board really in, I can't remember now, maybe about late February in the middle of the COVID crisis. It was presented to the board and it was broadly accepted. Just given the madness that was going on at the time, it wasn't formally endorsed. That may or may not happen. I hope it happens. And in fact, one of the recommendations that we did ask for was that standards for infection control become basically college standards for accreditation. And I think this is important. The standards are written really with a view, one, to provide some guidance, but really, and we made this very clear, that the standards, the document that we've produced is also written for our administrators. I think mandatory standards, make it so much easier for doctors to get funding for this equipment. So one, the document as presented has been reviewed and broadly accepted by the Board of College of Intensive Care, and we have asked that these standards become accreditation standards for college accreditation purposes. Whether that happens, I don't know.
Okay, thank you. We use Tegaderm as our probe cover to reduce cleaning and HLD or LLD after use based on procedure. This ensures we have a quick turnaround time. What do you use?
We use sterile probe covers, yeah. So we don't recommend them. I mean, they provide an inconsistent barrier. I mean, they do probably minimize soiling, and they do, they're not doing nothing, and they probably do increase efficiency with disinfection cleans. I think as long as you're doing a good disinfection afterwards, that's more important. But just don't overestimate the benefit that you're getting from a sterile cover. The sterile covers are they're actually quite expensive. Our covers cost between $5 and $7. And when you compare that with a $2 to $3 cost of high or low level disinfection, they are quite expensive. And again, I think we worry about the cost of disinfection way out of proportion to the other money that we spend on infection control, including on sterile probe covers. For example, an inline suction catheter costs about $22. If a patient goes into a room and then the patient is changed, we're spending $800–900 just on disposables. If that patient changes, we throw out $800–900 worth of stock. We're spending vast amounts of money elsewhere on infection control and practically nothing on ultrasound.
Thank you. This next question, Westerway and Basil found the cable of the probes to be highly contaminated. Does the group recommend products that are only capable of disinfecting the entire device to the correct level, not just the handle and probe distal end?
No, it includes cables as well. I didn't include it in my talk, but we absolutely include cables. The thing is that we can never get full clearance as to, if the cables wear out and they become contaminated, they'll simply just have to be replaced. But yes, no, anything that's high frequency, that would include cables, of course.
Okay, Dr. Castello, thank you so much. That looks like that is all of the questions that we have for the presentation today. On behalf of Germatech, who sponsored the webinar, we'd like to thank you for taking the time to join our session. Thank you and enjoy the rest of your day.